Hello everyone. So today we'll discuss about how to read X-ray and how to approach the different findings in X-rays. So X-rays are really important when you appear for your final year MBBS exams, when you appear for your NEET PG as well as INICET exam, as one question or two question is are definitely asked for X-rays, and when you appear for your MD final year exam. So today I'll try to complete the approach of X-ray in such a way that you will be able to correct the questions that will be asked in NEET PG and INICET, as well as you will be able to clear the viva of your final year MBBS as well as for your MD level exam. So coming on to how to approach a X-ray, initially you have to tell whether it is a erect film or a supine film. So for erect film, you can see there is this gastric bubble on the left side. So if the gastric bubble is there, it suggests it's a erect film. Then you have to tell whether it's a PA film or a AP film. For that, you should know that while taking an X-ray in PA projection, your hands are folded backwards. So the scapula is on not covering the lung fields, and the clavicle are more oblique. So if clavicle are oblique and the scapula is not covering the lung field, then it favors PA projection. While if scapula is covering the lung field and the clavicle are more horizontal, then it favors this AP view. So this X-ray that is shown here is a PA film. Now you have to tell whether the X-ray film is rotated or not, because rotation can really hamper the findings. So you have to tell whether the film is rotated or not. You can tell this by seeing the spinous process in the middle and checking the distance between the spinous process and medial end of both the clavicle. So it should be equal. So if the distances are equal, then the film is not rotated. And if one distance is more than the other, then the film is rotated. Then you have to tell whether the film is adequately exposed or not. So for that, you have to see the vertebra behind the cardiac shadow. So if the vertebral spaces are just visible, then it is a adequately exposed film. If vertebral spaces are more darker and are very well visible, then it is a overexposed film. In overexposed film, there are chances that you can miss pneumothorax or miss lesions. While if the film is underexposed, that you are not able to see the vertebral spaces behind the cardiac shadow, then there is chances that pseudo consolidation can be seen, like white lung field will be seen, which may be normal, but because of underexposed film, it is looking white. Then you have to tell whether the film is inspiratory or expiratory. Then you will tell me in the comment section how you can tell whether the film is inspiratory or expiratory. Okay. Now coming on to what cardiac structures are there forming the borders of the lungs field. So on the right side, we have SVC. Below SVC, we have right atrium. So on the right side, we have two structures. While on the left side, we have the uppermost structure as aortic nickel, then we have pulmonary conus, and then we have left ventricle. And if the left atrial appendage is enlarged, then also it can come just above the left ventricle. So this is the normal cardiac structures. Now, how to tell whether there is a cardiomegaly or not? So you have to calculate this CT ratio, that is cardiothoracic ratio. And how to calculate this? You have to measure the widest transverse diameter of the heart, that is A plus B here, and then you have to measure the widest intrathoracic diameter, that is C here, and the ratio is A plus B divided by C. So if the cardiothoracic ratio is more than 50% in adults, then we can say there is a cardiomegaly. If it is more than 55% in infants, then there is a cardiomegaly. And if it is more than 60% in neonates, then there is a cardiomegaly. Now coming on to RA enlargement. So for RA enlargement, we measure the distance from lateral border of vertebra, that is the vertebra and the lateral border of the heart on the right side. If it is more than 3 centimeter, or if we measure from midline, then if it is more than 5 centimeter, then we call it as RA enlargement. And if maybe the height of the RA is more than three intercostal spaces, then also we can call it as RA enlargement. So in what conditions you will find RA enlargement? RA enlargement can be seen in PAH. It can also be seen in AST. It can also be seen in tricuspid stenosis or tricuspid regurgitation. Okay. Now, coming on to LA enlargement is really important for your Viva, for your NEET PG exam. So, how to tell LA enlargement? So, one thing is there is upward displacement of the left bronchus because LA lies just below the bronchus. So, there is upward displacement of this left bronchus as we can see here, and it is the earliest sign. Then we have, because of the upward displacement of the left bronchus, the carinal angle is widened. So normal carinal angle is 50 to 70 degree. If it is more than 70 degree, then it suggests LA enlargement. Then there is stubble density of the rights on the right side, because one density is because of the right atrium and another density is because of the left atrium, which is enlarged and comes to the right side. Then there is enlargement of LA appendage, which can be seen just below the pulmonary conus. Okay. And enlargement of LA appendage is pathognomic of rheumatic etiology. So in exams or in vivas, mostly we get a case of rheumatic mitral stenosis, and in that we can have this LA enlargement. Now in this X-ray, we can see there is cardiomegaly with a cardiothoracic ratio almost more than zero point 0.6 to zero point 0.7. Now in this X-ray again, there's slight cardiomegaly, but the difference in these two X-rays are here the apex is mostly of left ventricle type. So LV is enlarged here, while in this X-ray, the apex is upturned. So it is because of right ventricular enlargement. So this X-ray is a case of a patient of TOF, as we can see the boot-shaped heart here, and the apex is found by right ventricle. Now coming on to pulmonary arterial hypertension, how to tell whether pulmonary artery hypertension is there or not on the basis of X-ray. So if you get a case of mitral stenosis, then you have to tell whether it is associated with PH or not. So in that, you have to see the dilatation of right descending pulmonary artery. As you can see in this X-ray, the right descending pulmonary artery at the right hilum is dilated. And how can you tell whether it is dilated or not objectively? If it is more than 16 mm in men and more than 15 mm in women, then the right descending pulmonary artery is dilated. Another sign to look on X-ray is prominent pulmonary artery segment, which comes just below the aortic notch on the left side, as I am pointing here. Also, there will be pruning of peripheral pulmonary arteries because of the pH. Now, in this X-ray, what you can see? In this X-ray, the pointers are on the horizontal lines, which are curly lines. So on the base, you will see curly B lines. On the apex, you will see curly A lines. So these suggest pulmonary venous hypertension. That is, the LA pressure is more, and due to which pulmonary venous pressure is more. Those curly lines are seen in heart failure. It can be seen in mitral stenosis. So this is the spotter. Another thing is this X-ray. So in this X-ray, we can see there is a bat wing appearance. That is the hilum and up to the one third to two third of the lung parenchyma is white out, and it is more in the up zone as compared to the lower zone. So this suggests cardiogenic pulmonary edema. Now in this X-ray, you can see the cardiomegaly is there. The carinal angle is more than 70 degrees. So LA enlargement is also there, as you can see on the left side as well. So the LA appendage is enlarged, LA is enlarged, and also there is cardiomegaly and apex is of LV type. So this type of X-ray can be found in patient of mitral regurgitation, because LA enlargement will be there, LV enlargement will be there. Now this is another X-ray. So the findings in this X-ray are, you can see there is RA enlargement, as can be assessed by the diameter from the lateral border of the vertebra, and also it is covering more than 3 vertebral spaces. And then there is a huge cardiomegaly with cardiothoracic ratio of 0.7. Also, we can see pulmonary oligemia is there. That is, on the lung field, it is more darker. So, and there is this very big shaped heart. So, if given the clinical history of cyanosis, this X-ray is more suggestive of Epstein anomaly because of the pulmonary oligemia, box-shaped heart, and significant RA enlargement. So these are some important slides. I'll come up with more discussion on the X-rays and more spotters on the X-ray. Till then, study well and subscribe to this channel for more such videos.